Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Volodi, and waving to me on the other side of the screen is Stacy Taylor. Now, anyone who's been around any type of Down syndrome-related behavioral discussions, you have likely heard the name Stacy Taylor. Stacy is the clinical director of the Advanced Behavior and Learning Program near Orlando, Florida, and she has graciously decided that she would like to address some topics with us too. And I'm so glad because one of the things that you all do as our listeners is you send me questions. And many of the questions that have come by recently have been behavior related. So I feel like ever since I asked you, Stacy, to come and join me on this podcast, I've been saying, hey, here's another question I got. So I think we've got a lot to talk about today. So thank you so much for joining us.
Oh, yes. I'm thrilled to be here. Thanks for having me. I love hearing from families and I love talking to other people who do similar work to me. So this is going to be a lot of fun. Let's get
going. All right.
Going.
Well, why don't we start with this? Tell us a little bit about who you are, what you do, why you love doing it.
Oh, wow. That's a great question. All right. Well, I've been in the field for over 20 years, and I've worked primarily in pediatrics from about birth to about 22, but I've really worked with all ages and stages throughout my career, working primarily with people with developmental disabilities, people with autism, people with Down syndrome has really been my career focus. And then about 15 years ago, so I think I've been in the field for about 23 years. And then about 15 years ago, surprise, I gave birth to a child with Down syndrome. So that was fun. I always joke that somebody somewhere said, she thinks she's so good at this. Let's see if she can do it 24 hours a day, 7 days a week. So she'll be 16 this year. So that was an added fun bonus to our family and to my life. And of course, that kind of renewed and I think really got me interested more and more in the field and the work that's happening for people with Down syndrome, because in my field, behavior analysis, and honestly, in a lot of the fields that I've kind of dabbled in, my doctorate's in special education, and I'm a doctoral level behavior analyst, we've always worked with people with Down syndrome, but we're so well known to work with people with autism, which has always been a frustration for me. Even before my daughter was born, I worked with everybody. We worked with people with ADHD, with people with autism, with people with Down syndrome, with people with genetic differences that had no name. Mm-hmm. But I know in our community, the work that we've done has never really been kind of in vogue. It wasn't the thing that doctors recommended the day your child was born. And I always kind of questioned, well, why?
Yeah.
This is stuff that really helps people. It's such an important part, I feel, of good care and treatment. So it's really been important for me to kind of weasel my way into the community a little bit and try to get my voice heard. And by my voice, I mean the larger voice of behavior analysis and the important things that are being done and how we can further help all of the amazing people with Down syndrome in so many different ways.
So let's say you're riding down in the elevator with somebody and they say, what's a behavior analysis? And you got to finish it before you get down. What does that even mean, behavior analysis?
It's the science of learning and behavior. Not about what we teach, it's about how it's taught.
Yeah.
Are we at the floor? Did we make it?
That's fantastic.
What? That's it. Yeah.
So Stacy, I love it. One of the things I love about you too, as we've gotten to know each other better over the years, is that you have an approach sometimes to some of these common behavioral topics. It may bring some different nuances and different approaches than perhaps we've even talked about on this podcast. So I want to bring to you a couple of questions that listeners have sent to us. You give me your approach to it, and then we'll talk about some other topics that perhaps we've even addressed on the podcast before, but maybe you have a different kind of viewer take on it. I'd love to bring that up for the audience.
Absolutely.
As well.
Absolutely.
Awesome. So one listener sent us a message saying, hey, I have a child who has a tendency to say bad words to this person. They said, they were saying shut up or go away or I don't want to do that, things like that. And they wanted to know kind of what's a good approach to that. So I'll just leave it out there for you. What do you think? What would be some approach?
That's a great question. Yeah. And I think it happens, so naturally when you parent, right? I mean, I love that you didn't start by saying this is a 12-year-old with Down syndrome, because it really doesn't matter. It could be any kid at any age with or without a disability, right? I mean, this is what parenting is. So I think number one, we need to just say at the outset, sounds pretty typical to me, right? Because that's part of what happens when you parent, is that your kids go through phases like this often. Some will stay there longer than others. So the first thing is It happens. The
Yeah.
second thing is we need to look at what's the frequency, what's the intensity, and how do we get this to be under some sort of control? Because we certainly don't want it to happen for too long, too much, too severe. Then we need to make sure that if those things are all in check, we're like, okay, it happened once. Well, we're not going to do anything about it. But if it's something you're like, no, it's been going on and it's getting worse, then we decide we need to move forward with some sort of plan of action. Mm-hmm. If it's for attention, and I was going to go back to when people come up to me at cocktail parties or, at conferences, as it were, and say, probably more conferences, if I'm being honest, and go, what do you do about a kid who curses? I think the real answer is, well, why are they cursing? Yeah. What's the function, right? You go back to that why, because we don't do anything about behavior, truly. And that's why we stopped calling it behavior modification a long time ago, long before I got involved in this field. We call it behavior analysis. For a reason, because what we're really analyzing is context, right? We're looking at the context of that behavior. Why do we think it's happening? Is it happening for attention? Well, if it's for attention, then I think you need to start considering things like planned ignoring. Mm-hmm. Then you need to start looking at, well, how do I really make a plan to ignore this behavior in a systematic way? You can really kind of do proactive teaching with your child and go, look, if you say these things to me, I'm not going to pay attention to you. These are no-go behaviors. You can do visuals. You can help your child understand. If you want my attention, you say these things. These are green choices. You say these things, these are red choices. Mom will walk away. I'll go to my room. I will close the door. So you can do a lot of good teaching to help your child understand. These are yeses, these are nos. But what if the behavior is for escape? What if it's to avoid? What if you have a child who comes home and you say, it's time to do homework, and your child starts cursing at you? Do you want to ignore that? Yeah. I think that you have to kind of take a different approach in that function, right? Like you have to really kind of go, wait a second. If I were to walk away, my child might go, that's how you get it done. Yeah. I win. Yeah. So you have to kind of really be thoughtful as to the why, because if it was for escaping or avoiding a demand, as we say, like a homework assignment or cleaning up their room, then I would say that ignoring becomes less important. Certainly, I don't want you to respond emotionally on level 100 because that never works, but you might be able to attend on a lower level while keeping that instruction present. So you might go, no, thank you. I need you to go clean your room. So the clean your room or the do your homework stays present, but you're also kind of staying, you're keeping that kind of attention, I should say, piece. It's still neutral, but present. Does that make sense?
It totally makes sense.
Yeah. So function matters is, I think, the point.
Now, what I'll hear from families is, okay, we've tried, let's say it is attention-seeking variety, and we've tried the planned ignoring, they'll say, and it doesn't work because they escalate. They do more and more and more of it until I respond. So how would you respond to that family?
Oh, no. And you know what? I would probably look at that family with all sincerity and go, well, that makes a lot of sense. And I'm sure you probably want to say the same thing. And it's so hard in that situation because so often we think we're going astray when the behavior goes up, right? But in actuality, sometimes that means we're doing exactly the right thing, because sometimes when behaviors have a history of reinforcement, right? They have a history of this works, this works, this works, this works, and then you turn that off, behavior will explode. We have fancy names for this stuff, right? It's called a process of extinction, and that explosion is a burst. It's called an extinction burst. And when we see that burst, as parents, we'll see that and go, oh my gosh, I just broke the kid. What have I done? I'm a terrible mom. I'm a terrible dad. I'm a terrible grandma. So we stop. And the dangerous part of that is when you stop, you end up reinforcing something all the way up here that maybe started all the way down here. So you have to be really thoughtful when you do extinction. In fact, we don't ever recommend extinction for severe problem behaviors for that reason, because we know they're going to burst. We know it's going to explode. So we're very cautious as behavior analysts to tell families, if you have a child, a teen, an adult with aggression, with self-injury, with severe property destruction, do not do a procedure like this, because I'm guaranteeing it's going to get worse before it gets better. So in those cases, you really don't want to do anything like this unless you've worked with a professional, you have somebody with you, you have emergency procedures in place, because it's going to get pretty bad before it gets better. Now, on the flip side of that, if you have a kiddo who's yelling and cursing at you, you're probably going to be okay. And it's going to be okay. It's going to be safer. If you have a little one who's whining, crying, nagging, fine, that's safe. So you have to kind of know what your putting on extinction, if you will, what
Yeah.
you're ignoring in this sense. Okay.
Yeah.
But no, that may not mean they're on the wrong track, if you will. That probably means that they're on the right track, which is it's frustrating, isn't it?
Yes.
Yeah.
It's about I guess in some respects, it's about keeping the eye on the prize. Eventually, this will be for their benefit and yours as well.
It will be, but the
yeah.
consistency of that implementation matters. So you also have to know, like, if I'm starting it, I have to be ready to start it and I have to be ready to finish it. Okay. So I'm very much of the mind, I never make families feel guilty about not starting it, because I'd rather them not start if they're not going to finish it. What you're going to get is you're going to get more and more higher levels of behavior. I'd rather them just wait. If you know grandma's coming in town, it's almost Thanksgiving break, don't do anything like that. That's just insane. Just wait and start the procedure after Thanksgiving when she leaves, because you know everybody's going to be giving in over Thanksgiving break. It's Thanksgiving. So be thoughtful about when you're going to start a procedure like this to make sure you can follow through. Yeah. And that's really important. And it's okay to wait. In fact, I'd rather you wait. So
and making sure that everybody who's in that home is going to be a part of this, because otherwise it'll fail. Okay.
Absolutely. Yeah.
Okay. Now let's think of another type of like impulsive kind of activity. Let's think about a child who every time they get their toys out, they just want to dump them all over the place, scatter them everywhere. And that's fun for them. They don't want to play with the toy like you would expect them to play with it. They just love seeing things crash, or maybe their cup go flying or their plate go off their table. People maybe have maybe even told the family, okay, this is something sensory that your child is doing. How would you approach it? How would you analyze that type of behavior to know exactly what's going on?
Yeah, that's a great question. Sensory behaviors are tough. Number one, they're tough to analyze. And that's why we often say, sensory behaviors are those ones that kind of occur across conditions. Mm-hmm. And one of the kind of hallmark features of a sensory behavior is, do they happen no matter who's in the room? Is it, that's how you kind of know, like, does it happen whether you're there, you're not there, if everybody's around, if nobody's around, if they're by themselves? It's kind of like, oh yeah, that happens all the time. That's how you know it's sensory. And sometimes with things like toy dumping, table clearing, and some of those more sensory style behaviors, we really start looking at things like, well, what does this child's engagement look like? I have this little phrase that I use with families always, and I've been using it for years. And it's just this concept of, there's a lot of benefits to being busy. There's a lot of benefits to engagement, whether you're talking about a 2-year-old or a 32-year-old. Mm-hmm. And it's so important that we think about, well, how is my loved one engaged actively? How can they be engaged independently? How can I be engaged with them in an effective manner? And what does that really look like at all of those different ages and stages? Some people can self-engage really well. Some people can't. And by the way, that's with and without a disability, mind you. So, and certainly having a disability can impact your ability to create your own engagement, to sustain that engagement, to come up with new leisure activities. It can compromise all that. For some people, you might have less of that. So you need to make sure you're looking at your loved one's ability to engage themselves. And then if they don't have it, how can we support it? Are there visuals that are needed? Are there timers that are needed? Is there a particular instruction that's needed? You'd be surprised how many times I go into a house, do an assessment, or I'm on Zoom like this, doing an assessment with a family, and I just go, well, what's your child doing right now? They're sitting. Doing what? So it's easy to give a kid an iPad. It's easy to give a kid, a movie to watch. But then once that's over, what's that? What do they have to do? What can they do on their own? So trying to give them ways to engage with a lot of different types of sensory input activities, visual activities, kinesthetic activities, fine motor, gross motor. All of those types of things are going to create more engagement and less opportunity, and frankly, less need to engage in some of those problem behaviors, whether it be a kid who's screaming because they want your attention, or a kid who's dumping things for sensory reasons.
Yeah. So almost, and correct me if I'm wrong, but it's almost like it's a replacement of what you don't want to see them do this behavior. So you give them something else to engage them similarly.
Sure. Yeah, it can be a replacement or an alternative for some kids. It just depends on the type of behavior. If you have a kid where the dumping is really the only thing that they want to do, then we need to think of a true blue replacement would be, well, let's find something they can dump that's appropriate. Like all they want to do is see things fall. They just want to see things fall. They just want to see things fall. And if that's truly at the end of the day, we've tried teaching, how to do a puzzle. Well, that's fine. That would be considered an alternative, right? But it's not a true blue replacement, direct replacement, because they want falling objects. So then we have to think of, well, what would appropriate activity be for falling? You'd be surprised how often we will come up with games that include that. But the game is they have to drop things into this bucket, and the bucket is where the things go anyway. And now we've got an activity. So we can create activities around some of these sensory experiences that are appropriate and not destructive and not disruptive, but that still meet that child's need, meet that adult's need, and it's where they're at. And that's okay. Like I have a kid who loved to rip things, which is, goodness gracious, if you left a piece of mail on a counter, you could say goodbye to that piece of mail. Okay. So the parents like, what am I supposed to do? And I'm like, well, what can he rip? And she's like, nothing. I'm like, well, I don't know if we're at nothing. So can we give something? So we created a ripping bin, just paper in a bin that he could rip. And when he sat at that bin, we provided reinforcement like you would not believe, praise, high five. We would cheer every time he sat there and rip. He thought we had all lost our minds. Yeah, that's fine. He also stopped ripping everything else because he knew he could sit there and have free access to rip these little tiny pieces of paper in this bin. She ended up putting sandpaper in there, construction paper, all different types of paper. He loved it. Yeah. And he never touched anything else in the house again. Wow. So everybody was happy at the end. And of course, it was a phase. He stopped ripping paper after a while because sensory needs tend to, as any parent will have, I'm sure has shared with you, they tend to go in these waves. So the ripping paper didn't last forever, but whatever that need was, it got met, and then he moved on.
I wonder if I could get you to explain to my wife that I need a bubble wrap station for me. I need to pop bubble wrap sometimes. You know what I mean?
I love that. I wish I could explain to my husband, I need constant massages all the time. I need to follow behind me like this, but he won't listen to me either. You advocate for me, I'll advocate for you.
All right, perfect. Well, let me throw another one at you. This one's totally different than what we've talked about so far.
No, this is great. It's like Jeopardy for me. So
yes. This is for, let's say, an older child or adult with Down syndrome who in social situations, particularly, let's say maybe they're getting a little bit nervous or uncomfortable, they're new people they're around or something like that, they start to fall back into patterns of what we would call scripting, where a favorite movie, they just keep replaying the roles, and they'll do the actor, and then the other person will respond, and they'll go back and forth with themselves, almost as what I would think would be more of like a calming mechanism type of thing. Is that an issue, or would that ever become an issue that you would be more concerned about?
I think the way you just described it is a really interesting scenario. And I think that you gave a lot of context to that behavior. And I think as families listen to us talk about this, that is what I would ask them to do, is to think really carefully about the behavior in context. The way you just described it was, to me, a person who uses this under particular conditions. They're in a new situation that is making them maybe a little anxious, if I can use an internal state here. I don't want to make an assumption of how someone feels, but let's say the person might be feeling a little bit uncomfortable and is using it to what sounds to be a coping mechanism. Is that almost what you're describing? Does that sound fair? I feel less uncomfortable, and I would be less apt to provide treatment, if you will, about it in that particular context. I feel like, well, they're getting it done. You know what I mean? Everybody needs a strategy. And if that's theirs, I would be less apt to jump on board with a plan for that person. I would counter that, though, with someone who uses that type of talk on an ongoing basis across conditions, in a variety of situations, with less discrimination, if you will, where and I've talked with a lot of families where they're like, oh no, like we could be, sitting at the kitchen table all of a sudden where we're going, Timo Mizumi, Gio, Millie, no. And the parents are like, eat your eggs. Like, what's happening? Like, what's going on? Why now? So I feel like there's kiddos on a spectrum of self-talk where one sense seems to be functional, and then we have another side that is very non-functional. It's the non-functional kind of self-talk that I get a little more concerned about, because this non-functional self-talk that's not so much this internal discussion, although yours wasn't either in your, but I know there's some families who say, look, I'll have my loved one might be talking to themselves, but it's outside of their inside, instead of inside their head, it's
Yeah.
outside and I can hear them, where they're planning their day, they're talking themselves down.
Yeah.
Should I be worried about that? And I almost always say no. I'm like, it's just an external dialogue instead of an internal dialogue.
Mhm.
We all do that, right? Where I'll be like, okay, then I got to go to the store, and then it's going to be fine though. I'll be there by 2. A lot of times people with Down syndrome will do that just verbally and vocally. And then you'll just want to look at them and go, I can hear you. Do you know I can hear you? But you don't want to be rude, but you're like, that's fine.
Yeah.
That's fine. Nobody cares. So I think those things, I find those very functional. But again, there's a non-functional, almost stereotypy, where you see this kind of non-contextual, sometimes even non-functional speech of singing, babbling. Sometimes it's movie lines. But they're almost always, I call them non-functional because they're unrelated to the present context, right? Not related to conversation that's happening, not related to I'm in an environment that's maybe unfamiliar, unnatural for me. And I would try to look at some sort of intervention with a better coping mechanism, because I think that type of communication is certainly not helpful for the person.
So the difference between those two scenarios that you said, one is that where it's more of a specific kind of situation that they find themselves in, that they will go to maybe more of a self-soothing scripting, talking out loud type of thing. But clarify for the audience a little bit. So when would it be concerning? Because this particular person who reached out to me said that it's almost happening all the time. Like anytime somebody's trying to interact with this person, they just want to do movie lines.
And see, that's why I always say, well, see, that case, I would almost be a little bit more concerned, because when it's non-contextual, when it's non-functional, you get a higher frequency, and therefore you get more disruption in social skills, in language skills, in work skills, et cetera, et cetera, et cetera. In your first example, to me, that'd be very situational, where, okay, well, maybe in that moment, they're just a little bit, well, I'm a little nervous, so I'm going to do this. But then later on, they'll be checked back in and you're talking to them and it's gone. So I think when you have a higher frequency, I think to help clarify, then you need to start looking at, again, contextually, when's it happening? Under what conditions is it happening? And then what can we teach as a potential replacement? Sometimes I always tell families, the first thing you have to do is name that behavior. We're so afraid of behavior sometimes, we don't want to talk about it. Like, well, if you don't talk about it, how will they? How are you going to discriminate it? So if you got to call it something. If you want to call it, pretend talk, silly talk, self-talk, whatever you want to call that thing, you have to tell your loved one, not right now. Not right now. We're at the table. Not right now. You can go, if you need to go take a break, go take a break. But right now we're at the table. You need to answer my question. Answer 3 questions, and then you can go take a break. Whatever it is, so they can start building up this idea of, okay, I can't do this right now because I'm sitting and talking to you. I need to wait. I need to hold my thought, and then I'm going to go take a break, and then I can go engage in whatever's in my head. If it's for sensory reasons, sensory behaviors can be discriminated just like any other behavior, but it is about teaching yourself some self-control. Like right now, you don't have bubble wrap, but you're making it. You're making it through this conversation.
Making it through.
You're making it through, even though you're like, I'd rather have bubble wrap. It's true. I'd rather have my neck rubbed. It's true. There's a lot of sensory behaviors that we all like, that we really, frankly, prefer. But we know how to wait. We know how to take a pause. We even know, like, if I have an itch on my foot right now, I can't take my shoe off right now. I'm in the middle of this podcast. So I just have to kind of deal with that itch for a minute, right? So even if it's something like that, we all can develop this self-control. Anybody can develop that, but it has to be taught often, because without that discrimination learning, people will take off that shoe and hold up their foot and start scratching it. And I'm sure you've seen that. I've seen that in classrooms. I've seen that in therapy sessions where you have to go, oh no, that's not appropriate. You have to keep your shoe on. Yeah. Actually, you can't do that in the middle of the restaurant. Yeah. So just even, little things like that, and teaching, we have to wait to do the silly talk. Yeah. Oh, that was silly talk. That doesn't count. Answer my question. Where are you going after school? That's good. That was a good answer. So teaching some of those things and really helping that discrimination learning is going to get yourself really far with those tasks.
Yeah. Awesome. Thank you. I really appreciate so far, as we've been talking about, the behavioral analysis and the approach to these behaviors that you, I'm sure, hear a lot of and deal with a lot of it through your clinic. There comes a point, I'm thinking, that for many different types of behavioral issues that you are looking at, that you start to wonder, okay, what's the next step? We've tried these different interventions. things don't seem to be progressing. How do you proceed with your patients, your families, to get them the care they need?
Well, it's a good point, and I think it's a really important question because we deal with a lot of families who have difficulties, whether it's with things like, self-talk or impulsivity, which we chatted about today. And they often have questions like, is this a comorbid diagnosis? Do you think this is ADHD? Do you think this is autism? Could my child have an anxiety disorder on top of having Down syndrome? And of course, the answer is sure, all of that's possible. Just like a person without Down syndrome could have any one of those three diagnoses I just mentioned. So it's really important that the behavioral side works with the medical piece. We work a lot with pediatricians and developmental pediatricians, psychologists, psychiatrists, neurologists, a host of different specialists to make sure that kids are getting well-rounded treatment and assessment and care, because we find that, behavior interventions can do a lot, and they can really help support learners in making great gains. But there are certain things that might have some sort of medical foundation. And that's where you guys come in to kind of do that assessment of, all right, what behavioral approaches have you tried? How consistent have they been? What does the data look like? And then what's left over, for lack of a more sophisticated term, right? If it's an iceberg, how much have you chipped away? And then how do we maybe step in? And is this possibly a medical piece that we need to address, particularly with things like attention and impulsivity and anxiety?
Yeah, for sure. Yeah, we've had so many patients over the years that have come in with a behavioral diagnosis. They're not improving on this or that medication, and as it turns out, they in fact had a medical issue that needed to be addressed before those behavioral interventions or medications might have even been effective. So
100%.
yeah,
because you might even have something like a sleep apnea or
totally
thyroid.
Yeah, totally. Lot of hidden masqueraders we see in this population, especially. So, well, we have really talked about a lot of different topics today. What are some things, if any, that you think we definitely want to make sure we hit on during this podcast? Are there things that we haven't talked about yet that you want to make sure that you share with our listeners?
I think that, as parents sit in meetings, whether you're talking about a young child in an IEP meeting, or you're thinking about a teen or adult, whether you're doing a transition meeting, or maybe you're working with, an employer, I think to approach conversations from a teaching standpoint and not just from a reduction standpoint is so important. People often will come in and want to talk to me about, I want him to stop doing this. I want him to stop doing this. He's got to stop doing this. And I'm like, well, hold on. Let's look at this from, what does your child need to learn to do? And what could they learn to do that would make all of those behaviors go away? Problem behaviors are always a result of weak or challenged repertoires, right? So you don't engage in problem behaviors if you have strong repertoires. So teaching and learning is at the foundation of everything that we do. So it's a huge piece of how good therapy intervenes. It's a huge piece of what good ABA looks like. It should always be about what we're learning, not what we're reducing. So I think so many families want to talk to a person like me and go, make them stop the following 12 things. And I'm like, you're not going to like me very much, because I'm going to be talking to you about, why is he tantruming at the math worksheet? Not, how do we stop his screaming when he sees math? So we really need to kind of look at those things. And then we can start looking at some of those problem behaviors and see what's left. But I think when you start addressing things from an acquisition standpoint, a learning standpoint, and kind of go, is this really a can't? Or is it a won't? Is this really something that your child just isn't doing yet because they don't have the skills yet? And then what are those skills? And how do we start filling in those skills? And what does that look like? There's so much great research on effective teaching strategies that we should be using more and more of, and that we're just not tapped into yet. Errorless learning, good prompting strategies, good fading strategies. And I think that if we can get our families bringing those things to their meetings, making sure those are on board for their kids, you're going to see less behavioral challenges every single time without a behavior plan, without anything super fancy involved. I think you're just going to see improvement with all of that stuff.
I love that approach, because if we focus on the end point of this is the behavior we're seeing that we don't want, Well, you might try to address those things, maybe not so successfully, but if you can teach those concepts wise, it almost makes it more easy to generalize to other things that may come up later on in life that you could address
100%.
in that way. Yeah.
Right. Well, I tell
Yeah.
people all the time that, the idea is to make problem behaviors irrelevant, ineffective, and inefficient. The moment that problem behavior becomes irrelevant, ineffective, and inefficient, it goes away.
Yeah.
And the best way to do that is by teaching something better.
Yeah.
Teach something that works better. So if you
Yeah.
have a kid who's screaming for attention, give them a better way to get attention. They won't need to scream anymore.
I
If
love
you have
it.
a kid that's cursing at you because they want to get out of math, teach them a better way to get out of math.
Yeah.
Everybody should have the right to get out of doing math. It's just about how you do it.
Yeah.
I mean, I got out of math a lot. I just knew I was savvy.
Yeah.
So teach your kid to be savvy.
Mhm.
Everybody deserves these repertoires. It's just some kids pick it up along the way, like breathing, just like nothing.
Yeah.
And some kids need direct instruction in how to avoid better. It's not that you can't be avoiding. You just have to know how to do it without hitting people, without running away, without dropping to the floor. But avoidance isn't the problem.
Yeah.
I mean, we're all avoidant a little, right? You're just better at it. So we just have to, I always tell people, so teach your kid how to do it better.
Yeah.
Teach them how to go sharpen their pencil for too long.
Yeah.
Teach them how to go, wait 1 minute, I'm almost done, just like all the rest of the third graders do.
Yeah.
And I mean, so all of those skills and strategies that are so developmentally appropriate, a lot of people with disabilities just don't learn naturally. They
Yeah.
learn problem behaviors because they work more effectively, more efficiently, and they're darn relevant. So we have to really turn the tide.
I love it. I love it. Yeah. And I think I'm sure that many of our listeners are like, okay, we have to go to see this Dr. Stacy Taylor and get more information. In fact, even some of the last things you were saying, I'm like, there's almost a podcast in each and every one of these topics that you just talked about.
Yeah.
So what I would love to say to our listeners is, the National Down Syndrome Congress has a annual convention each year. This year happens to be in Dr. Taylor's Orlando. And so I know she'll be there. She'll be doing a deep dive session, which is a long 3-hour session on behavioral analysis techniques. And of course, during the convention, I'm sure you have many workshops that you'll be doing. As always, we keep her very busy during the convention, and for good reason. And so if you're interested in finding out more about this, but also any other topic, please do come on out to the convention this year. Orlando, I mean, you can't ask for a better location for a convention, right?
So the weather's going to be nice and hot. Please don't wear long sleeves.
Okay.
It's hot now. It's what is it, March? Yeah. So yeah, we'll have good weather for you. It's going to be beautiful. And I will make sure to also give you our direct contact information. So any families listening, if they want to reach out, we do virtual consults all over the country with families. We know that, getting people to connect with can be hard. Particularly people who know how to work with people with Down syndrome using behavior analysis in effective ways. And we're happy to help. We want to be there to support families in as they move through these kinds of issues. So please feel free to share that. We're happy to help however we can.
Awesome. And to our listeners, we do thank you for the questions that you sent today that helped to spur this great discussion. And we ask, if you have any other questions that you would like us to discuss of any topic whatsoever, please send me an email to downsyndromecenter@chp.edu. I do read each and every one of those emails, and I do try to find speakers that can help to address those topics with us. For those of you who are interested in joining with us in the work that we do here at the Down Syndrome Center, including this podcast, please do go to givetochildrens.org/Down Syndrome Center, and we will gladly partner with you in the work that we were doing. But until next time, bye-bye.